Hey everyone, welcome to Clean Quest. We'll be starting with the next video of pediatrics PYT discussion, where we'll be discussing breastfeeding, nutrition, and malnutrition. These are the important PYTs that has been asked from these topics. So first, we'll start with something called breastfeeding guidelines. What are the guidelines for breastfeeding? The guidelines starts with initiation. When are you supposed to initiate breastfeeding? You should start breastfeeding as soon as possible after birth, with or within 1 hour. Doesn't matter if the baby is delivered vaginally or C-section. You should start within 1 hour after delivery. Next is, what is exclusive breastfeeding? Exclusive breastfeeding is for the first 6 months of life. The baby has to receive only breast milk, nothing else, not even water. Water is also not required because breast milk has adequate amount of water for the need of the baby. You don't need to give extra water. Next is, when to start complementary feeding. What is complementary feeding? Complementary feeding is the semi-solid food that is started at 6 months and after 6 months. So we'll start at 6 months and continue. Along with the complementary feeding, we have to continue the breastfeeding. So it is not that you are starting complementary feeding, you should stop. You should continue the breastfeeding. Along with breastfeeding, you have to give semi-solid food called complementary. This is called complementary feeding. So you should give after 6 months. What will happen if you give before 6 months? So if you give before 6 months, the baby has the risk of developing something called celiac disease. Baby will develop something called celiac disease. So that's why we should give after 6 months. Next, how will you store the express breast milk? So for storage of express breast milk, if it is at room temperature, it can be stored for 8 to 10 hours. If it is in a refrigerator at a temperature of 2 to 8 degrees centigrade, then it can be stored for approximately 24 hours. But if it is in a freezer, it can be stored for 6 months. Next is, what are the signs of good attachment? How do you know that baby is attached to the mother's breast, nipple areola? So how will you know the baby is attached properly to the nipple areola complex of the mother, known as good attachment? How do you know the baby has a good attachment? So first thing in good attachment is something called positioning. How will you position the baby? The baby should be positioned in a straight line. What do you mean by straight line? The occiput, the shoulder, and the buttocks should be in a straight line. It's not like the bent neck or something. The baby has to be in a straight line. This is the position of the baby. Next, how should be the mouth of the baby? It should be wide open. What should be the position of the lower lip? It should be everted, and the whole areola should be covered by the mouth of the baby except the upper part, which can be visible. What do you mean by this? That is, if this is the breast, the whole thing should be covered except this portion. This whole thing should be covered except this upper portion, which can be visible from above, or else the whole thing should be covered with the baby's mouth. This is what should be the position of the mouth. Then chin of the baby should touch the mother's breast. These are a few points you should remember. Question has been asked on this before. What should the position of the baby? Baby's occiput, shoulder, buttocks should be in a straight line. Mouth should be wide open. Lower lip should be everted. Whole areola should be covered by baby's mouth except the upper part, which can be visible from above. And chin should touch the mother's breast. Baby's chin should touch the mother's breast. These are the signs of good attachment. Next, we'll be discussing something called variation in the breast milk composition. So we'll divide it into two things. One is based on the postpartum, time duration after postpartum. Another one is based on the each feeding session. So time after postpartum, 3 kinds of breast milks are available. One is your colostrum, another one is your transitional milk, another one is mature milk. So when you will get colostrum is secreted first 72 hours right after birth. It is thick, it is yellow in color, and it is rich in antibodies. This is colostrum. transitional milk for the next week after 72 hours, and followed by next 2 week we have something called transitional milk, and mature milk, which is watery. After the first 2 weeks you'll get something called mature milk. So for the first 72 hours you'll get colostrum, next 2 weeks you'll get transitional milk, and after the 2 weeks you'll get mature milk. This is the this is the composition depending upon the duration after postpartum. Another one is depending based on the feeding session. Each feeding session has two kinds of milk. One is your foremilk, another one is your hind milk. What is foremilk? Foremilk is that milk which is secreted first when baby starts sucking. It is watery in consistency. So if it is watery in consistency, so it will quench the thirst. While the hind milk is richer in fats, it has fats. So if fats are there, then it will satisfy the hunger. So foremilk is watery, it satisfies the thirst. Hind milk is fatty, it satisfies the hunger. So this is about the variation of the breast milk composition depending upon time duration after postpartum and depending upon each feeding session. Next, how do we know the baby has adequate breastfeeding? What are the signs of adequate breastfeeding? There are three things. One is after each feeding session, baby will sleep for approximately 1 to 2 hours. Baby urinates for 6 to 8 times per day, and consistent weight gain is there. These are the three things you should look for to know if the baby is having adequate breastfeeding or not. Okay. These were all about the guidelines of breastfeeding. Next we'll go to the composition of the breastfeeding. What will be the composition of the breastfeeding? Composition of the breast milk, not breastfeeding, sorry. So composition of breast milk has so many things. The most important ones are carbohydrates, proteins and fat. Carbs are present around 7, protein 1 and fats 3.4. These are supposed to be not milligram, these are gram. 7 gram per dl, 1 gram per dl and 3.4 gram per dl. Now one important thing that has been asked several times is the difference between breast milk and cow's milk. This was a PYQ so many times. So I made a table. It contains everything which needs to be remembered. So you have to remember it. You have to read up a few times and revise it so that you can remember. Among everything is you can remember lactose is more in breast milk, protein is more in cow's milk, but this was a PYQ. What kind of protein? So in breast milk we have something called whey protein, and cow's milk we have something called casein. How do you remember? Breast milk is given by whom? Woman. So W for W is whey, and cow's milk is given by cow. C for C, so it will be casein. C for C, casein. Woman, W for whey. So this is how you can remember. Cow's milk is rich in casein, and breast milk is rich in whey protein. Now fat is more in cow's milk, 4.1, and in breast milk it is 3.4. Carbohydrate is more in breast milk, it is approximately 7, and in cow's milk it is 4.5. Calcium is very high in cow's milk, it is approximately 120. Other than that, iron is 1 and 0.2. Water is approximately same, 87, 88 and 87. Energy is also same, 65 and 67, approximately same. So this table you need to remember everything. Make sure you remember this thing. Cow's milk has casein and breast milk has whey protein. Next, what are the advantages for the baby? Advantages of breast milk for baby. As we have discussed, breast milk has something called whey protein. Whey protein helps in CNS development. Also, it is rich in PUFA and DHA, which supports brain development again. PUFA is polyunsaturated fatty acid. Next, what are the anti-infective substances that are present? These are TGF-beta, IgA, lactoferrin and phagocytic macrophages. These are the anti-infective substance. Then it reduces the risk of a few conditions like NEC, necrotizing enterocolitis, asthma, obesity and diabetes. Also, baby will have higher IQ, maternal child bonding will be stronger, and it contains all the vitamins except which vitamin D and vitamin K. This was also a PYQ. Which vitamins are absent in breast milk? It is DK. You can remember DK. The cricketer Dinesh Karthik, you can remember using DK. So these are the advantages of breast milk for the baby. Now what are the contraindication when we cannot give breast milk to the baby? So there are two kinds of contraindication. One is your relative, another one is your absolute contraindication. So relatives are what? Relative contraindication are maternal HIV infection. So this is only for developed countries like USA and stuffs, where if the baby has HIV, if the mother has HIV, we cannot give breast milk to the baby. But in countries like India or other developing countries or underdeveloped countries, we have to give breast milk because it is the main source of nutrition for the baby. No other thing can, no other supplement can give everything in an adequate proportion like breast milk. So in developing countries like India, we have to give breast milk. Okay, this is only for relative contraindication for HIV, only for developed countries. And if there is active infections are present, like mother has TB and active varicella zoster infection, then this is also a contraindication for breastfeeding. Now what are the absolute contraindication? The absolute contraindication, if the baby has something called galactosemia, as you all know, then we cannot give. And if the mother is on chemotherapy and or radiotherapy, the mother is in chemo or radio, we cannot give. And if the baby has something called galactosemia, these are the absolute contraindication for breastfeeding. Okay, so this was all about breastfeeding. I've tried to cover everything. Next we're going to start malnutrition. It's one of the hot and examiner's favorite topic. Questions from malnutrition is like a go-to topic for the examiner in every exam. So you need to know thoroughly about this topic. First we'll see what are the indicators of malnutrition. The indicators for acute and chronic are different. For acute malnutrition, there is something called weight for height. We'll look for weight for height. And for chronic malnutrition, we'll look for height for age. These two things will decrease, right? Decrease in height for age and decrease in height for weight for height for acute malnutrition and decrease in height for age for chronic malnutrition. So what is weight for height is called? It is called wasting. Decrease in weight for height is called wasting, and decrease in height for age is called stunting. So if weight is decreased, you can remember, if weight is decreased, then the baby is having some acute condition, acute malnutrition is there. And if it is the height cannot decrease overnight, right? It has to be like it will take a subsequent it will take a duration which is longer than the weight loss, right? You cannot lose height overnight, but weight can be lost overnight. So that's why for acute condition we have to remember, we can remember it as a weight, and for chronic condition we have to remember it as a height, which will take longer duration to decrease. So decrease in height is for chronic condition, which is also called stunting, and decrease in weight for height, not weight for age. This is important. So many people does mistake. It is not weight for age, it is weight for height, is for wasting. Acute condition we need to see weight for height. For chronic condition we need to see something called height for age. Okay, so what is wasting, what is stunting, what are the indicators of acute malnutrition, what are the indicators of chronic malnutrition? This has to be remembered. These were all asked in previously. Next, WHO classification for malnutrition. WHO has classified malnutrition into two. One is moderate malnutrition, another one is severe malnutrition. So in case of moderate malnutrition, the things you need to see, there won't be any edema. The weight for height, it is between -2 and -3, and for height for age it is between -2 and -3. So weight for height and height for age are between -2 and -3, and there is no edema. These are the criteria for moderate malnutrition. But for severe malnutrition, there is edema. Edema is present. That's why it is also called edematous malnutrition. The SD score is less than -3, for both weight for height and height for age, called severe wasting, severe stunting. So this is the classification of WHO. It divides it into two things. One is moderate, one is severe. The main difference is there is no edema, and -2 to -3, -2 to -3. Here it is -3, -3, less than -3, -3. So this you need to remember, classification. Okay, so next we'll do something called, the name of the topic will be your protein energy malnutrition, PEM. This is two things. One is your kwashiorkor and marasmus, which is a very important topic, very like another important topic in this chapter, which has been asked several times before. So as the name suggests, there is protein and energy malnutrition. Okay, so baby will have or the child will have less protein intake and less energy intake, that is carb intake. Now which one is what? So in case of kwashiorkor, there will be in terms of energy, if we talk about energy, there will be marginal energy will be there, but in case of if you talk about protein will be insufficient protein will be there. In case of marasmus, both energy plus protein both will be insufficient. Okay, so energy in kwashiorkor baby will have marginal energy, but protein will be insufficient. But in case of marasmus, both protein and energy will be insufficient. Now this table I have made, which will cover everything about everything, the difference between kwashiorkor and marasmus. You need to remember it. So the main differences that we can talk about is the kwashiorkor baby will have edema, then apathy will be present. Apathy means baby will have loss of interest, doesn't want to eat, will have doesn't interest to go out, play and everything. Completely loss of interest you can talk about. Then appetite will be very poor. Baby will have lethargy. Hepatomegaly is present. Then skin and hair, we have two things we'll see in them. One is called flaky dermatosis, flaky paint dermatosis in the skin, and hair we'll see something called flag sign. I'll tell you what this looks like. In case of a marasmus baby, there is no edema, main differentiating point. Then apathy is also absent. Baby is a good appetite will be very good. Baby will be a voracious eater. If you give food, baby will eat. Unlike your kwashiorkor, hepatomegaly is not there. Also, baby is active and alert, doesn't have lethargy. The skin and hair conditions are not present in case of marasmus. So these are the main differentiating point you need to remember between kwashiorkor and marasmus. So this is how the marasmus and kwashiorkor baby looks like. In kwashiorkor baby have something called moon-like faces. Then see the hairs, these will be thin hair. Okay, then a bulging abdomen because of your hepatomegaly. Also, if you can look below, you will see something called edema, which is present. Okay, this is how Kwashiorkor baby looks like. If you look at a marasmus baby, hair will be thin, but not as much as Kwashiorkor. There won't be any moon phases, and there is no hepatomegaly or bulging abdomen. There is no edema. Okay, these things are not present in case of marasmus. So these are the main differentiation point between Kwashiorkor and marasmus. What are the So you need to remember which one has edema, which one doesn't have edema, which is a voracious eater, which is not, which is flaky pain dermatosis, which is hepatomegaly. You need to remember everything. This is what I was talking when I said the hair will have something called flag sign. What is flag sign? See, the whole hair is black, but in between there is a discolored portion. It has become white. So this is called flag sign. And this is how the flaky paint dermatosis look like. Okay, you'll see white flakes. These are also seen with, I think, vitamin B3 deficiency also. Okay, so this is all about your Kwashiorkor and marasmus. That is the protein energy malnutrition. Next is severe acute malnutrition, or which is commonly called as SAM. What is the definition? This was PYQ several times. The definition is one or more of the following. Among these three things, one or more. Not necessarily. So many people have this idea that you have to have all the three things. Not one. It's not necessary to have all the three things. You need to have only one or more than one. It doesn't matter. You have to have at least one. In a child of age 6 months to 5 years. So among these three, one or more in a child who has age between 6 months to 5 years. Now, what are these three things? One is weight for height, which is -3. Weight for height is for what? It is an indicator for acute. We have discussed. This is also an acute condition. We're talking about severe acute. So weight for height should be less than -3 standard deviation. Mid upper arm circumference, which is also called as MUAC, should be less than 11.5. In the previous video, we have discussed about what instrument we use for measurement of mid upper arm circumference, which is we use something called Shakir's tape. You can go and check. And there has to be bilateral pitting edema. So one among these three, if present in a child of age 6 months to 59 years, then we call it as severe acute malnutrition. This is the definition of severe acute malnutrition. Next, how will you manage the management of severe acute malnutrition is a huge thing. There are 10 steps and stuffs, but you don't need to remember everything. You need to know just the overview. How will you manage? They haven't asked like everything about this chapter about the management. Whatever is important I have added. First, you have to hospitalize the child if the child has complication or very poor appetite. In acute condition, you have to hospitalize the patient to treat the complications. Now, treat the complication. How will you treat the complication? What are the complication? So we use something called shielded approach. Shielded is kind of a mnemonic. That is, we used to see what are the complications present. So shielded is used for complication. What is as for sugar? As for sugar deficiency, there is hypoglycemia. What is the definition of hypoglycemia? If RBS is less than 54 mg per dl, then it is called hypoglycemia. How will you treat it? You have to give something called 10% dextrose IV. Next, age for hypothermia. When the rectal temperature is less than 35.5 centigrade, then it is called hypothermia. You have to manage by warming the child, removing wet clothes if baby is wearing. Then Infection, I for infection. How will you in infection? Give antibiotics. Next, EL for electrolyte imbalance. In a severe acute malnutrition child, the main electrolyte imbalance that is seen in one is hypokalemia. There is low calcium, low potassium, and high sodium. These are the main two things that are seen in a severe SAM child. Also, hypophosphatemia is there, so you have to correct it by giving supplements. Okay. Next, D for dehydration. You have to rehydrate the baby using reduced osmolarity ORS, not the traditional ORS we use. We have to reduce, we have to dilute that ORS and give. Available one known as Resomal, which has a reduced osmolarity. It has high potassium and low sodium. Reduced osmolarity, high potassium, and there is low sodium. As the child has low potassium, high sodium, so we are giving something with the high potassium and low sodium in Resomal. Next, deficiency of micronutrients. Main deficiency which we have is something called iron deficiency. We have to give iron supplement, but not during the acute management. We should not give iron supplement during acute management. We have to give it during rehabilitation period. Rehab mein we have to give. Why not given in acute condition? Because iron will lead to growth of something called E. coli in the gut, which will again leads to malnutrition. So that's why we are not giving it in case of in the acute condition. We'll give it in the during rehabilitation. Okay, to prevent the E. coli growth. Now, rehabilitation, nutritional rehabilitation. What kind of nutrition we'll give to the child? As the child, the main condition is acute malnutrition, right? So we have to give the children nutrition. What kind of nutrition we should give? Initially, when during acute hospital admission or during acute condition, we have to give something called F75. Now, what is F75? It has 75 kilocalorie per 100 ml of food. So initially we have to give something called F75. When the child will start improving after probably a few days, then we have to give something called catch-up diet. It is called catch-up diet, which is called F100. Means we have increased it from 75 to 100 kilocalorie per 100 ml. So we are gradually increasing. Later, during the rehab period, we are giving something called RTUF. What is the full form of RTUF? Ready to use food. Ready to use. It is not RTUF. It has to be RUTF. Ready to use therapeutic food. Therapeutic food. RUTF. Okay. So what is the level of energy it has? It is something called 543 kilocalorie per 100 gram. So it is given in the later period, during the rehabilitation period. So this is how the nutritional rehabilitation is done, starting with low amount 75, gradually increase to catch-up diet, which is 100, and then we will increase it to ready to use therapeutic food. And following along with this, we can also start home foods. Whatever the baby is at that age taking, we start the homemade food also. So this is all about severe acute malnutrition. Next, when you will discharge the criteria, when you will discharge the baby of a SAM patient after admission. So if there is no edema for at least 2 weeks, and weight for height reaches minus 2 standard deviation or higher, or mid upper arm circumference is more than 12.5. So these are the three conditions we have to see. One is there should be no edema, one weight for height minus 2 standard deviation or more, or there is mid upper arm circumference which is more than 12.5 centimeter. So if this criteria reaches, you can discharge the baby. So this was all about the nutrition chapter. I have tried to cover everything that has been asked previously. Have I missed anything? If I have missed anything, you can let me know. I will try to cover it up in the next video. So yeah, one important thing is this rhizomal, ISOML. What is the osmolarity of rhizomal? The osmolarity is 300. Is 300 osmol. Okay, and it has low sodium and high potassium. So this is all about your breastfeeding, the guidelines of breastfeeding, the nutrition and the malnutrition. If I've missed anything, you can let me know. I'll try to cover it in the next video, and till then we'll probably start with the neonatology in the next video. And like this video, share and subscribe to this channel. Follow the Telegram channel. I'll post the MCQs and PYQs of this nutrition and malnutrition chapter on the Telegram channel. You can solve it from there, and there's a Google form on the description. You can write you can fill up the Google form to let me know if any important topic which you want me to make videos on, or if you want to give me any suggestion or any kind of queries you want to ask. You can fill up the Google form. Link of the Telegram channel will also be on the description, and I'll post this PDF also in the Telegram channel. So until next video, thank you for watching and study harder.